Our next panelist will be discussing provider challenges and solutions. Matthew Madaus is the president and CEO of Edgewood Center for Children and Families in San Francisco, the oldest children's charity west of the Mississippi. He leads a staff of more than 500 in their work to provide quality care to over 7,000 children and families in the 9 Bay Area counties. Mr. Madaus oversees Edgewood's residential treatment facility, non-public school acute and intensive services, and school-based and community-based programs in San Francisco and San Mateo counties. Prior to joining Edgewood, Mr. Madaus was executive director at Victor Community Support Services and the chair of its statewide training work group. Mr. Madaus has managed inpatient, residential treatment, school-based and community-based programs in both California and Massachusetts. Mr. Madaus was selected to be a member of the Workforce Education and Training Committee of California's Oversight and Accountability Commission. A licensed clinical social worker, he received his Master's of Social Work from San Diego State University and completed his postgraduate program in Intensive Family Systems Therapy from the Family Institute of Cambridge. David Pilon received his doctorate in social psychology from Harvard University in 1981 at the age of 10. A licensed psychologist, he is the Chief Executive Officer and President for Mental Health America of Los Angeles. In 1989, he was the lead writer for the grant writing team that produced the successful bid to design and implement the Village Integrated Service Agency in Long Beach. He has consulted in the design and transformation of mental health programs and systems throughout the United States, New England, and Japan.
New England is separate from the United States.
and New Zealand.
That's right.
A past president of the California Association of Social Rehabilitation Agencies, he currently serves on the Evaluation Committee of the Mental Health Services Oversight and Advisory Commission. He has presented numerous workshops on ethics and leadership issues in psychosocial rehabilitation and on developing outcome measures for social rehabilitation programs. From 1999 through 2007, he served as the lead for the collection and analysis of data documenting the effectiveness of the integrated services for the homeless, also known as AB 34, a program serving nearly 5,000 people who are mentally ill and had been incarcerated and or homeless. Dr. Pilon is the co-creator of the Milestones Recovery Scale and has served on the Performance Measurement Advisory Committee for the California State Department of Mental Health. He is the principal writer for the California Institute of Mental Health's Full Service Partnership Performance Measurements Toolkit. Please welcome Matthew Madaus and David Pilon.
Good morning. So I'm going to talk for a little bit, for about 15 minutes, trying to keep it to around 15 minutes, and then David's going to follow up and he's going to present for a bit, and then we will have some time for questions. My presentation, because I oversee a children's behavioral health agency, is really going to focus on services to kids. So I think there's most of the real gold nuggets are going to be how you can find solutions to some of the collaboration and funding challenges in working with kids. My hope is that for adult providers that there will be some pieces you can pull out as well and extrapolate how to apply that. I'm going to talk about different partnerships with federally qualified health centers, and then some private program models, both in terms of funding and business models, and then some key learnings that we've had at Edgewood around this. So first of all, in terms of partnering with a federally qualified health center, there's basically 2 ways to go about it. There is positioning, stationing, and embedding a behavioral health consultant at the FQHC, or having them provide a pediatrician for us or other physical health provider at your location to support the clients with behavioral health needs. The first piece is trying to figure out which FQHC to partner with. There are FQHCs all over the place, and many of them are already providing behavioral health services. Many of them are already partnering with other folks. So my strategy was actually just to make cold calls and talk from one exec to another and say, I'd love to just sit down, learn more about what you're doing, see if there's any possibility that we could collaborate. My experience was that several times, I did this both up in Sacramento as well in San Francisco, several times there were rabbit holes that I had to go down. So I would have meetings, I'd have conversations, and either they weren't interested, they were too busy, the interest was primarily in adult or only children and adults, or some other reason that it really didn't proceed. But in each situation, with a little bit of determination, I was able to identify a partner, and the thing that I looked at first and foremost was a partner that was interested in collaborating. So I really did not want to simply send a clinician out to the FQHC and have them be kind of left on their own. I really was looking for a deep partnership, someone that could enrich the services at the FQHC and provide something in turn for our agency as well. So the basic model for providing a behavioral health clinician in an FQHC is a consultation model. It's a little bit of a misnomer because it's not exclusively consultation to the physicians and nurses. It also can include short-term treatment. It can include groups. Sometimes the treatment can go up to 8 or 10 sessions, but generally the model is to have a warm handoff and to either see the client at that time or to set up an appointment to see them and then have 2 or 3 sessions for 20 minutes or a half hour, really providing information and really trying to catalyze that process. The other direction is to have a physical health provider. For Edgewood, it was a pediatrician that was stationed at our campus, and they were doing similar kind of model where they were doing 20 to 30-minute sessions, sometimes consulting with our staff around physical health needs. And that both of those models can be very successful, very helpful for both sides. The funding for FQHCs for the behavioral health consultant can work in one of 2 ways, in my experience. One is it can be a fee-for-service arrangement where you negotiate a rate whereby that behavioral health clinician in the FQHC, every time, every visit they have, you are getting paid some rate. So when I was working with a clinic up in the Sacramento area, I negotiated a $90 rate. They were getting quite a bit more than that. We were the subcontractor. This put the responsibility on the clinician to make sure that they were having many, many visits. Now, you do the math, and pretty quickly you can see that you can actually start to make a fair amount of money. However, you cannot be billing, you cannot be recouping for services on the same day as another service. So if they went in and saw the dentist, saw the physician, and they got a warm handoff, you cannot bill for that same day. So if you set up an appointment for them to come back, you can bill for that other day. So sometimes there's a loss of that revenue. So you need to be thoughtful about doing the fee-for-service model. So I have experience doing that model and making that work. It has to be the right clinician. You have to get a clinician that, frankly, is not heavily invested in relationships and is much more focused on outcomes, providing the information, getting them to the place where they can kind of use this information and then move on. The other funding model is a cost reimbursement model. So the arrangement that I have with a clinic in San Francisco is basically they pay for the staff's time, along with fringe, along with program indirect, and along with agency admin on top of that. And then the clinic works with that particular staff person to make sure that they're recouping a reasonable amount. So I set that up in San Francisco because they really wanted a lot more consultation to the staff, to the nurses and physicians in particular, and oftentimes that's simply not billable. So I didn't want to take the risk of the fee-for-service model. So those are a couple considerations on the finance side. So I want to talk a little bit about some of the conversions that we have done at Edgewood, converting our publicly funded programs into being funded by private health insurance. We started this out 7 or 8 years ago with just a kid or two at a time under a contract with Kaiser, where Kaiser was invested in keeping kids out of the hospital. So we developed a 2-week model where Kaiser would pay a daily rate. We then, over time, started to expand that to 3 or 4 kids at a time. We started to contract with other insurance companies, typically using the health insurance code for residential treatment, but the selling point was that it was very short-term residential treatment and it would divert the youth from hospitalization. So in marketing to the health insurance companies, the thing that we have kept looking at, kept coming back to, is really what is the sell for them. And the primary sell that we have found, there's a little bit of expanding their service continuum and consumer satisfaction, but it's primarily how are we going to help them save money? How are we going to help them move youth out of the more acute services? So move them out of the hospital into our hospital diversion program. So that now has grown to typically somewhere between 8 and 14 kids at any given time. After we developed that, we then had a number of kids that it was difficult to serve them in 2-week periods of time. Some other kids that would go back to the hospital because they would go from our hospital diversion program back to outpatient services. And the outpatient services oftentimes were 1, maybe 2 times a week. So we basically converted our day treatment program that we've had for a number of years into a partial hospitalization program. So that youth could step down from that hospital diversion program into the partial hospitalization program. Then the natural next step, about a year later, was to develop an intensive outpatient program, which is generally 3 times a week for 3 hours, and there's a number of different requirements. There's a number of requirements both for partial hospitalization and for intensive outpatient that are specific to the health insurance requirements. So the health insurance companies are overseen by NCQA, and they have NCQA, the Quality Assurance, National Quality Assurance Standards, require them to meet certain standards. So we have to help the insurance company appreciate we are meeting those standards in our program. What we're launching right now through SB 82 is we've got a crisis stabilization unit funded through the county that we're now actually selling to other insurance companies. So particularly, again, going back to Kaiser. Kaiser tends to be the one that leads this. And they're planning on buying a couple slots, and then we'll expand that to other insurance companies. So now for the first 3 programs, we now have contracts with the 9 major insurance companies in the area, and we get referrals pretty steadily. So a couple things I want to point out if you're to look at some of these. Actually, let me go back. You'll see the last one I passed right over because it's crossed out. We are not providing any outpatient services through health insurance funding. We're doing a lot of EPSTT work. We're doing a lot of wraparound work. But we have not been able to negotiate the appropriate rates for outpatient services with health insurance companies. The major benefit of the higher end services, the more niche services, is you can set your own rate. So our experience has been that we set a very high rate, much higher than in the public sector, and then we negotiate for contracts with insurance companies. So the outpatient services, if anyone has any way that you're actually able to crack that code, please let me know. I'll buy you lunch. On the capacity side, we've learned pretty quickly that intake needs to happen very quickly, and there needs to be some sophistication. It needs to be a licensed clinician who can identify the medical necessity that justifies them being in such a high level of care. You also have to weave in authorization. So you need an intake clinician who's got some savvy, some ability to work with the clients while they're also talking to the insurance company and speaking the insurance company's language. We now have developed intake, so we have intake capacity 24/7, but that absolutely is not required. What you really just need is a designated person that can respond quickly and a designated number that they can be calling. Psychiatry and nursing for us was a really big selling point. Our nursing staff does a full nursing assessment and works very closely with our psychiatrists. We have several psychiatrists, but we also have residents through UCSF. So we're really fortunate to have that, and that's been a selling point. It's certainly possible to do these kind of milieu programs without nursing. It's just a bit more difficult, and you need to really have the physician capacity if you don't have the nursing capacity. So those things have been real selling points. Oftentimes when we're getting referrals from psychiatric hospitals, there needs to be a doc-to-doc conversation, and if there isn't a doc-to-doc conversation, the hospital may not want to refer to us. Clinical services are more intensive in these particular programs. One of the things we've tried to invest in is getting really good outcomes so that we can continue to sell the programs. There are some facility needs. So in looking at serving a population that is particularly acute, you need to be cognizant of your facility capacity. So if it's on the residential side, there needs to be absolute safety. You know, we've had a number of kids who will, just like in a psychiatric unit, are going to be swallowing the shampoo, and, do we need to take their shoelaces and different things like that, as well as should it be on the second floor? Should we have bedrooms on the first floor instead? So there's a lot of facility capacity issues that have to be considered. The route that Edgewood has gone of having the hospital diversion and the partial hospitalization and the IOP is not the route that it has to go. So if you don't have a residential program, you certainly can develop a partial hospitalization program or just an intensive outpatient program. You also need to have the capacity around administrative systems. So you need to be able to track the authorization, make sure that everything is filled out absolutely perfectly, or the billing will be denied. Make sure that you're collecting copays, make sure that you are tracking and invoicing and collecting things appropriately. The actual components are very similar to many of the programs, the publicly funded programs that are out there. So you need to do a comprehensive assessment. You need to do it much more quickly, but it's basically the same assessment. Milieu and group treatment, intensive family treatment. One of the things we found is that actually, because most of these are kind of crisis-oriented programs, the families are very engaged. So you need to have the capacity to respond to them and to work with the families 2, 3, 4 times a week. Therapy and medication management is a significant piece. And then a lot of consultation with providers, consultation with the ongoing outpatient therapist, sometimes consultation with the school, and a lot of consultation with physicians. So business model, the interesting thing is the documentation for things like EPSDTs, some of the county required documentation is much more onerous than we have found for the private health insurance. We really can do actually a reasonable amount of documentation, which compared to the publicly funded requirements is much, much less. We really also have to focus on authorization. So that's an area where we've had a lot more QA oversight. So the couple different designs that I've already touched on. One is a step-down design. So this would basically be looking in your area, where is the real concern for health insurance companies? Is it hospitalizations? Is it day treatment programs? And then you look at providing a somewhat less acute, less intensive services that youth can or adults can step down into. The other is to have all of these and provide a continuum of care, and to have conversations or negotiations with health insurance companies about having covered lives, about owning all of the level of treatment and doing a per member rate so that you can just get $10 a month for 5,000 kids or adults. So the direction that Edgewood is moving, we started out exclusively as fee-for-service. With those different programs, we're now moving towards negotiating with the insurance companies to have 20 or 40,000 covered lives in the Bay Area, which is a very different model that I won't get into too much. Milieu mixing is something else that we have had a lot of conversation about. Basically, that means if you've got 1 or 2 clients, do you mix them in with your publicly funded programs, with your other programs? And it can be done. We've certainly done that with our residential program, but you need to be thoughtful about it in terms of the impact on the clients. If they're seeing, the long-term clients are seeing the other folks going through very quickly, that's something to think through. On the business model side, the rate setting and rate negotiation is a really important piece. Like I had said, you set the rate really high. and then you negotiate it down a bit. But what we have found is that insurance companies, once you've got a contract, once you've got a rate, they don't want to come back and increase it. So maybe you'll get a 1 or 2% increase. So if you're setting a rate, you really want to get that higher rate up front. The other thing we found is with getting contracts and rate agreements, that sometimes it's better to not have a contract. When we do not have a contract, we get a single case agreement and we charge our full published rate. The reality is that our referrals, very few of our referrals, with the exception of Kaiser, actually come from the insurance company. The vast majority of referrals are coming from psychiatric hospitals, are coming from ERs, are coming from private therapists in the community. So they come to us and then we contact the insurance company. And when there is a clear need for the service, they will do a single case agreement. So contracts do not need to be an absolute holdup. You can actually develop the program and then market it from there. Authorizations and utilization management I commented on, that's a really important piece, not just the initial authorization, but to track everything, that you're in compliance with everything that has been authorized, particularly in terms of timeframes. AR and collections, what we found is that actually the health insurance companies pay pretty darn quickly if everything is perfect. So they're pretty typically paying within 60 days, but if there is a word missing, or even we've had one experience where a word was misspelled, they kicked it back and started the 60-day clock again. But it is not like sometimes where you're waiting for a county contract for 6 months or waiting to be paid for 6 or 9 months. And again, you know, the relationships with the health insurance companies, once you've got the agreement set up, the contract set up, there's not much relationship. One of the challenges is being able to get in the door, find someone at each of these health insurance companies that you can actually talk to, sit down, and start to negotiate. So we've had some luck where we've had a couple particular senior staff who have relationships at these companies, and that's kind of opened the door. Marketing, we've actually had to invest quite a bit in marketing. Because there are consistently slow periods where we're not getting referrals, and we have to keep beating the bushes. We have to keep contacting the hospitals and other providers to make sure that we are getting the word out. Then we often will get a huge rush of referrals. Sometimes we can't manage it all, and then there's a churn and a high level of turnover. So one of the things we've learned is that you have to prepare for that. You have to expect that that's going to happen. And you need to have your rates appropriate with that kind of firehouse model that sometimes people are just sitting around and they need to be ready to go, and you're still paying them when they're sitting around. Diversification of funding has helped us a lot. As we've developed these more acute, shorter-term models, we've actually had conversations with counties, and we're now having county departments purchasing slots and purchasing beds of the same model that the insurance companies have been interested in. So this is something that I suspect will continue to happen more and more. The lines between the private health insurance and the public health insurance and coverage are going to start to get more and more blurred. Non-stop marketing, I mentioned, and the final piece is having the appropriate staff attitude, having really strong managers that can be coaching the staff to be prepared for short-term treatment, for a wide diversity of client profiles, and for really a different kind of relationship sometimes with the families. So I think that was my last one. Yeah, we'll come back to questions actually after the next presentation. Thank you.
Good morning. So I would like to start out by saying that I approach all of these challenges from the perspective of trying to retain our recovery-oriented, member-centered approach with all of the challenges that we face in this healthcare environment. But I'm going to focus on these three today: integration of behavioral healthcare and physical healthcare, the increasing and expanding relationship between behavioral health services and law enforcement, and the growing influence of managed care on our work. Particularly, I spend a bit more time on the first and the third, and a little bit of time on the second one. But I want to just review the fact that what does looking at these things from a recovery orientation really mean? And I tend to focus on the SAMHSA definition of recovery and sort of the four domains. I think that actually we do a pretty good job of focusing on the health and the home aspects and getting people off the streets and those kinds of things. But when it comes to meaningful roles or purpose on one hand, or helping people to integrate back into the community, I think we struggle a little bit more. So I really want to focus on the integration of behavioral health care from that perspective as well. I just need to mention a couple of caveats. We're a provider of services to people with severe and persistent mental illness. So to the extent that you serve people who are less disabled, some of the remarks today probably won't necessarily apply to you. And we're also exclusively in Los Angeles County. I know many of you actually provide services to a variety of counties. And, LA is extremely urban, and to the extent that you're out in the suburban or even the rural areas, some of this stuff may not apply as well. And I mean people 18 years of age or older when I refer to adults. And as my friend Cynthia Keller-Tinian would say, it's like, well, there's a lot of differences between adults and older adults. And even though I got my PhD when I was 10, I can still appreciate that now that I'm an older adult. So I just wanted to set the context for this integration of behavioral and physical health care, because I think that as behavioral health care providers, I know this is all obvious to you, but we're at a serious disadvantage when it comes to primary care in terms of the level of resources. This is from an article in the journal Health Affairs, and it was a study between 1996 and 2006, and they looked at the overall population and found that per capita spending for healthcare was about $2,600 per person, or about 95% of all of the dollars that went to healthcare went to primary care, where about 5.5%, little less than 5.5% went to mental health care. And the other interesting facts were the drug spending accounting for 26% of healthcare spending, but 51% of mental health care funding during that time. And again, inpatient mental health care accounted for 16%. So if you combine the 51 and 16%, that means that 2/3 of all the mental health care funding was being spent on hospitalization or on prescriptions. This doesn't leave a lot of money for the community behavioral health services that we're providing. And if you look at the fact that that's such a small percentage of the overall amount of resources, it really makes you think. And this is from the same article, which showed that the amount of real spending on physical health care went up, over that time, while the real amount of spending for behavioral health care remained flat over that time. So this kind of sets the context. It's like, when it comes to the dog wagging the tail, we are definitely the tail in behavioral health care. And I want to be the dog, okay? So we also need to think about, and this was talked about by George Scolari this morning, it's like, who are these new folks that are going to be served under Medicaid expansion? And I think that they're unlikely to be found to be psychiatrically disabled. I think that the vast majority of people who would meet the qualifications to be considered psychiatrically disabled probably have already found their way into our system. But that doesn't mean that a lot of them won't have a severe and persistent mental illness. It just means that they will not probably be able to get on disability, on SSI. And many of them will require extensive care coordination services. I think that this is the key to our success with this population as we move into behavioral health and primary care integration, is that if your agency is anything like mine, your staff spend an enormous amount of time on care coordination. This is what we do extremely well. And I want you to keep that concept in mind, because I think that when I get to that item about managed care coming in, this is what we have to bring to the managed care table, is our expertise in care coordination. So you all know, did you hand me my water? You all know that and it's been discussed this morning, that there are lots of different ways of integrating primary care and behavioral health. I have to tell you that my own agency has been spectacularly unsuccessful at co-locating our staff in FQHCs. I think there are a couple basic reasons for that. The first one is the scaling problem. It's like we've never been able to figure out how to adjust our staff to the varying level of behavioral health needs that the clients at the FQHC have. But the more important issue for us has been that FQHCs discovered that they can get another revenue source from the feds to provide behavioral health services themselves. And so they said, well, folks who are mild to moderate, we'll handle those ourselves. We still want you to take these ones who are really causing a disruption in our waiting rooms, but we'll handle this. So we haven't had much luck with that. But I think that what we have done in my own agency, I can share with you a couple examples of how we can become a behavioral health home. In Los Angeles County, there's funding from the innovations money through the MHSA for what are called integrated mobile health teams. And my agency runs an integrated mobile health team for the city of Long Beach primarily. And that's where we do actual street medicine for the most compromised and vulnerable people out on the streets of Long Beach. They have to have at least 3 co-occurring disorders to be admitted into the program. And what we have done is that the FQHC actually provides the physical, a nurse practitioner to actually provide the physical health care that goes along with us providing the behavioral health care. But we are in charge of that, in charge of that program. So the physical health care is attached to us because I think for our population, it's the behavioral health conditions that really drive the health care issues for folks, not necessarily the primary care. So we have this integrated team, we call it the Homeless Innovations Project, and they spend enormous amounts of time out on the streets. And I'll tell you that one of the challenges that we've actually experienced there is the high rates of death among our client population for untreated conditions that have gone on for, in a lot of cases, decades. And so one of the things that you need to be considering and working with this is how you support your staff with the issue that there are going to be a lot of people who have these co-occurring disorders that are going to die, and how do we provide the support for our staff to provide support for those folks. I think it's a really important thing to provide the possibility of death with dignity for folks, and in a lot of cases that's what we've been doing. The other area that I want to say is that we got a grant from the California Community Foundation to actually bring a physical health care provider, a nurse, and a care manager into our village program. And so 2 days a week, we actually have a doctor who comes in, and that program has been amazing in terms of actually helping people to get the care that they need. A lot of people have not had care for, in some cases, a decade. And in fact, I'll show you a short video, quick 5-minute video. Here's the questions that we asked the members for this video. Please describe the services that you received from Dr. Torno at the village. Why did you choose to receive services from Dr. Torno at the village instead of a provider out in the community? What do you think Dr. Torno does better than other doctors that you've seen before? And how has your experience with Dr. Torno changed your ability to get medical care, medical services outside the village? So I really honed down those questions into 1 minute per client, just so that you could get a feel for how our members experience this kind of care. And I think it speaks a lot to the issues that we talk about, why it's difficult to integrate behavioral care, and what, if you do have a good integration, sort of like what that experience will be for folks. So if you could cue up that video.
Considered kind of hard to get going or something like that. And so staff members like Ms. Kumi inspires me and pushes me to pursue checking myself out. Well, the whole medical issue, I think they've made me feel comfortable with the idea that people actually do care about you doing something about yourself. And if I already believe, because of the enthusiasm of both, that if I have a problem out there, I can come back here and something will be adjusted.
Dr. Torno is a more caring doctor. He cares about the patient. You know, you have some doctors that's just in it for the money, just to do their job, but he takes time and talk to you and listen to you and give you the best advice he could possibly give you. Well, I know that I would have had to suffer because before I was seeing Dr. Torno, I was going back and forth to the emergency room. I came here and my kidney was messed up and he sent me to the lab, and I went to the lab, they found out what was wrong with the kidney, they hospitalized me, and I got well.
Because I was homeless when I first came here. I just had come to Long Beach, and it was real convenient, it was close, and they made it real easy for me. They helped me keep my appointments by reminders and calling me frequently and stuff like that, or I probably would have flaked out. Dr. Torno, he's plugged me in the community with different doctors. I had a history of Hodgkin's lymphoma cancer, and I hadn't had a follow-up in over 10 years. And he gave me referrals to oncologists and hematologists and stuff that I wouldn't have got done on my own, that's for sure. He seems to know just about everybody. I mean, he's really on the ball. He makes he'll say something and then he'll be on the phone doing it. You won't have to wait for, paperwork or this or that. He'll just be getting it done right then and there. Yeah, I have a primary care doctor now that I have insurance. But for like 8 months I didn't, and he was my primary care doctor and he handled everything.
Dr. Torno has been like a blessing. He was a very excellent doctor that really wanted to know if the medication was working, if you needed a stronger or lower dose. He was really excellent with that, with following up with you as a person. I don't know how he did that, but he did it. Yeah, he kind of opened me up to the idea of finding a clinic and finding a secondary insurance than if I hadn't seen him.
And I found, okay, it's another doctor. You're used to the doctor with the clipboard. This guy actually sat down and talked to you. I mean, when was the last time a doctor talked to you? It's pretty incredible. It's like, I'd talk about this, that, and whatever. And just little things that I would need. It was like my primary care was messed up on my, the Medi-Cal. Calls up Medi-Cal, finds me a new primary care guy in the neighborhood. But he took care of it right then and there, which I thought was pretty bizarre for a doctor. You see that, but it really impressed me was his thoroughness of seeing everything through. I had a quadruple bypass a few years ago, and I think that's a pretty radical surgery. I think that's about as radical as you're gonna get, And it was like, the surgeon, I thank him, and I thank my lucky stars I had him. He's one of the best around. But, the bedside manner was like, it was like he was mad at you or something. I say, well, how's this going? Hey, I want to thank you. Yeah, sure. It's like, but not only that, his firsthand and his hands-on thoroughness of seeing every task or every little thing through. I mean, if Kumi tells me, gives me a referral for something, she'll email me 2 days later, because I might forget, and then say, did you make that appointment yet? Or do this, or do that. It's kind of cool. You don't get that, So that's all.
I'm considered kind of hard to
So that last member, I always feel like he missed his calling. He should have been an infomercial person. But I think that short video really sort of demonstrates a lot of the issues that our members face. But one of the surprising things, and I think we've been spectacularly successful, is that I knew that our members weren't particularly welcomed out in primary care facilities. But what has really happened is that this program has actually served as a bridge to other primary care facilities, so that we serve to help our members to actually get the care out in the community. They'll stay with us as long as they want, but it's not forever. And that was actually a surprise to me. I thought, well, they'll just get their primary care from us and that'll be fine. But real recovery means integration into the community, and I think that the program has been pretty successful with that. The other thing that I'll mention is that, and this comes back to hopefully being the tail that wags the dog, is that on July 1st, 2016, I intend to open a five-room primary care clinic for our agency that we will own. We're working with our local FQHC to actually staff that, but I want to have the primary care facilities that are designed for our folks, where our folks feel welcome. It won't necessarily be for them forever, but this is what I mean about becoming an FQHC, or at least collaborating with an FQHC. It's like we need to sort of be in control of the resources, because I think it becomes real easy for the typical primary care system to not provide the quality of care that our members deserve. I'm going to just touch on this really briefly, because I really would like to keep a little bit of time for questions. Many of you know that Laura's Law, AB 1421, has been implemented in several counties. And I just think that there's an unavoidable conflict between our role as social justice advocates and our role as service providers that we need to consider when these services come in. Now, my own agency was founded 105 years ago by a person with severe and persistent mental illness, and so advocacy has always been part of our mission. Some of you may not feel like that's as much of your mission, but you have to acknowledge that there is an issue in terms of balancing how are we going to provide recovery-oriented services when we are, by definition, sort of limiting people's civil liberties to some extent. Thank you. It's an issue for us, and I don't think that it's not solvable, but we have to consider how we look at that. I don't usually do this on slides, but I put up some transcript of a interview between Pat Morrison and a psychiatrist, Tom Burns, who's done a lot of work on involuntary outpatient treatment. And basically, what they found is that the court orders don't actually add to the outcomes. And so if we're going to limit people's civil liberties, we want to know whether it's actually having a positive effect or not. We can at least consider that. So I have the link for you so that you can actually go to the entire interview and sort of get the entire picture of that. But these are the issues that we need to consider. How do we minimize the coercive elements of the program? And like I say, the importance of evaluation. You should always be evaluating whether having a court treatment order is actually making a difference in the program or not. And there's also some business issues that we need to consider, is that it's probably going to be a lot more expensive to serve these people well. And so we need to consider, are we going to be expected as providers just to do our usual FSP services for no additional compensation with this population? In regards to, by the way, how do we minimize the coercive elements of this program? If you don't know Al Rolette at Turning Point Community Programs, you should introduce yourself to him, because I think he's run a program that's actually implemented Laura's Law in the least coercive way possible. So you really need to talk to Al and see that program. And I'm actually encouraged in LA County that the LA County leadership decided to go up to Nevada County and see that program and try to learn what we can do to make it as non-coercive as possible. The last thing I want to talk about, and sorry, I'm going to have to go through this fairly quickly, is that with managed care coming, there's a paradox in our work. Many of us got into this work for reasons of social justice and because we care about the disadvantaged. And I think that many of our staff got into this work for the same reason. And what we found, at least in my programs, is that the pressure under managed care to move people to lower levels of care may conflict with the part of us that wants to keep providing services to folks, perhaps even after they no longer need those services. So we need a rational means of, my underlying assumption is that 5 years from now, there will be no fee-for-service. It'll all be sort of capitated, and we'll all have to be moving people to lower levels of care. Matt, alluded to that whole continuum of care, step-down services. So we need to prepare for that the best way that we can. And so in LA County, we're actually involved in a pilot program to actually study that. And as you're all aware in your own systems, is that more and more high-need people are coming into our systems and are, creating bottlenecks of services because we don't have a rational way of saying, oh, when is somebody actually ready to move to a lower level of care? That's not to say that people aren't doing it on an informal basis and moving people to lower levels, but without some kind of formalized system, it becomes really difficult to do that. So we've actually integrated the 2 levels of care in this pilot project in Los Angeles County at the higher end of the system, FSP and what used to be called in LA County as FCCS, which we now call Level 4 and Level 3 FSP. And the county has allowed us to combine our funding sources for those. It was an administrative nightmare when somebody would move from an FSP level to an FCCS level, and then they had to move back, so we had to change their funding stream and that sort of thing. It was just causing us all kinds of administrative headaches. So this is really an opportunity to actually test whether we can actually create the flow in a rational way. So these are the criteria that we're actually using to determine when somebody is ready to move to a lower level of care. Does the client require support to manage their financial resources? Do they need support to coordinate their own transportation needs? Do they require formal or informal assistance with ADLs? These are the kinds of things, and every month we rate all of our clients in the system, in the pilot, on these to see if we're actually helping people to become more self-coordinating. Because that's the key, I think, to helping people to recover and to move to lower levels of care, is that they have to absorb more of the coordination of their own care, or acquire the capacity to self-coordinate their own care. So I can give you more information about this. This is the algorithm that we have for actually assigning whether somebody is level 4, level 3, level 2, level 1, and to then assign them to their appropriate level of care. The reason why this is all important is because the managed care companies will want to know, are we actually being successful in moving people to lower levels of care? And we should be held to that standard. These are just some of the initial data. So these determinants, quite logically, that if you have more of these determinants, you should be a higher cost. And so as people go negative on the determinants, their costs should go down. And that's what we find, is that people with no determinants averaged only $4,000 per person in the 6-month period covered by this, where people with 8 determinants averaged about a little over 12,000. But it's a pretty strong linear relationship between the number of determinants you have that you're positive on and how much you cost to the system. And whoops. Try that again. Thank you. I just want to show you really quickly. I had to put these data in last night, actually, because I just got this. We looked at the data for my own agency from January through June of this year on each of the 8 determinants. And what you hope to see over time is that when people come in, is that the determinants have a slope going down to the right over time, because you're actually helping them. They don't need weekly care coordination, or they don't need med management or those kinds of things. And so what we are finding, and this is just the initial data that are coming through, is that for almost all of the care, all of these different determinants of care, is that over time, so people came in, 50% of them needed support with their transportation. After 6 months, that was down to 20%. Money management, interesting, this is a lot sort of more jagged, but people came in at about 55 or so, 54% needing it. 6 months later, it was down to about 44%. Similarly, how many were needing medication management? About 65% when they came in. 6 months later, that was down to about 55%. So I'm going to stop there. All of these slides will be available to you. But what I want to point out is that the members and staff both experience significant resistance to this idea of flow. And that's because it runs counter to us to a certain extent. It's like we want to believe that we're needed forever for folks, but if we want to stay true to that ideal of recovery and reintegration into the community, both members and staff need to sort of like think about what that means. And the other fact is that these determinants have really helped our managers work with our staff in terms of asking, what does this person need to be able to move to a lower level of care? It really begs the question of what's holding this person back, and what do we need to do to help that person to move to a lower level of care? So managed care is coming. We can fear it and resist it, or we can embrace it on our terms and use it as a tool to serve the recovery of our members. I'm sorry, we're pretty close, but if people have any quick questions for Matt or me, we'd be happy to try to answer those. Anything? Hey, Deb.
Dave, I want to thank you for presenting on the determinants. And for those of you, when you get Dave's slides, please take a look at those determinants, because I think that Dave has led an effort, a provider effort, to really use 8 elements as a decision aid. And I think that has incredible value. That has incredible value if we are going to move in a direction where we have levels of care and services associated with those, and outcomes associated with those services. The second thing I just wanted to acknowledge is that I think you have both articulated an approach where you have built on, you have moved in a very intentional direction, I think, and to create behavioral health homes. And I think that maybe in a future presentation, focusing on how you built on, for the most part, MHSA-funded services to be able to do that, because I think that as counties and as providers within counties, it will be incumbent upon us to be able to build on the work, particularly of the last 10 years. And I think you both really laid the foundation about how that can be done very nicely, so thank you.
Yeah, thanks, Deb. Yeah, one of the things is that we had to go out and get a grant for that integrated healthcare system within our own agency. But Deb's right that the MHSA innovation funding was used to actually to provide the funds to pay the FQHC in our street medicine program. So those are actually mental health dollars that are going for physical health care, and you can't really find those very easily. So this integration from a behavioral health standpoint, as I said, is really difficult for us from a funding source to actually provide the physical health care. Do you want to add anything to that? No. Any other quick comments before we bring up the next panel? Sandra's coming up, so you better hurry. Yeah. Okay, thank you.
Thank you.